Okay, good afternoon. I hope everyone is still awake. This is my final talk today. We will talk about allografts in revision ACL reconstruction. No relevant disclosures. So as you know, in Pittsburgh, in the US, probably as a whole, we use a lot of allografts. In Pittsburgh in particular, which is where in the early 90s the transplant surgery started. And so Freddie Fu was intimately involved with the transplant surgeons and started using a lot of allografts also for knee ligaments. And we still do this today, but very carefully. And I will show you that good outcome can be achieved, but obviously not to steal the thunder, not in young people. But so the pros are, it's a customized graft. You can make it as small or big as you want, and there's no donor site morbidity. So you have a very easy initial rehab. It is markedly different. The cons is it does cost about $1,500 extra. You have a little bit delayed graft maturation and a bit of a higher re-rupture rate in young patients, which we are not using this for. Here are some properties of the different grafts. Tibialis anterior, quadriceps tendon. You see bone, patella tendon. Bone is actually weaker than those soft tissue tendons, but it's the fixation that determines your failure anyway, not the graft strength. So the negative factors, if you use allograft, do not irradiate it. If you do want to irradiate it for cleansing, then it should be only minimally irradiated. Prolonged freezing is no good. A donor that's older than 40 years is also not that good. And there's even some evidence on sex matching a male to female. So advantages, easy to fill the bone blocks. You see this massive lesion there, the cystic lesion. And on the femur, you can bypass the problem by going over the top, a procedure that Stefano described quite a bit and Freddie also used a lot. And so I learned from both of them, and I use that also. Here's an Achilles bone block as an example, and you can fill the whole defect and then turn it around if the tunnel is too anterior or too posterior. Like so. And then here's the over-the-top technique. Achilles allograft with a minimum of 22 centimeters will allow you to do the Macacci-Saffanini technique. Failures. It's really important to know the allograft may be one reason, but the main problem is tunnel position. Of course, there's bony morphology, the high slope, the narrow notch, etc., meniscal tears, and patient characteristics, the young patient at risk. So here's just a quick case example. It's a 35-year-old runner, runs more than 80 kilometers a week. They had a hamstring tendon autograft 13 years ago, and then recently a bike accident. Now they have lateral knee pain and instability. Here's the X-ray with this transtibial technique. You may think on the X-ray the tunnel isn't all that bad, so hold that thought. Posterior drawer has a slight posterior drawer, but mainly an anterior problem. And then here's the MRI, complete graft rupture, very posterior tibial tunnel, but you can't really see the tunnel positioned too well until you do a 3D reconstructed CT scan, and now you see the tunnel is nowhere near the anatomic insertion. It is too high and it is too anterior. Now you may accept that and say, I can sneak a tunnel posterior to it, but the easier way is you go over the top, like depicted here, and it works very, very well. It's a quite anatomic reconstruction. And then intraoperatively, you can see here there was a root tear that was fixed as well. And then this is with the Kelly clamp going on the over-the-top position, and the picture on the right shows the graft positioned in the notch. Fixation with staples rarely gives hardware-related pain. So this is our own study. It's about 400 patients, and the mean age is 40 years old. The mean follow-up is 5 years. And they had a very small revision rate of about 4%, and there was no difference between different allograft types. So based on this, this is really what our treatment currently is in patients over 40. They get allografts quite commonly offered. And here's some other studies. This is based on graft type, a higher revision rate for allografts, as you all know from Martin Lind's study, 12 versus 5%. Similar failure rates in this meta-analysis from Aaron Critch. And then Stefano showed that the quadriceps tendon had a much lower revision rate than the hamstring. And here's some mouse outcomes. Obviously, everybody knows this, but the higher re-rupture rate with allografts with a relative risk ratio of almost 3 and a higher failure rate. So in young patients, again, we do not use allografts. And then here's a meta-analysis. Gives a nice little table with some data points, but there's really no significant difference in any of the studied outcome parameters except the risk for failure with the higher odds ratio. So in summary, when it comes to revisions, be a detective, look at everything, look at all the concomitant injuries, especially the tibial slope, the lateral side, be well prepared. There's no such thing as a simple revision. Biologics can be considered, and be realistic with return to play. Thank you very much, and thanks for the invitation. Bye-bye.